and we do receive research grant support from Alcon, but has no relevance in this talk, and recognize the contribution of our colleagues at Raghukant Hospital, Ahmedabad and Jaipur. And time has now come to customize, as we know, for quite some time, particularly for presbyopia solution. And I'm going to share some real life scenario, but before I do that, we understand that there are various options we have, and monovision strategy has been there for a long time, even before multifocals and other technology came in, and it works well. And people do contact lens trial, whether they would suit in, and what is that mini monovision or large has been a strategy, but it's never caught on. I do know that there are good surgeons who continue doing it, but generally speaking, because of the asymmetrical visual performance, it's just never caught on, and people have relied on a symmetrical both eyes, generally speaking, and that's how the traditional multifocals came in. Then there was some improvement on some distance on the low ads, and then the trifocals came, and the trifocals really have changed our approach to the managing these patients' need and their lifestyle. There are now extended depth of focus lenses, which is a kind of a modified monofocal lens, but has an added advantage of depth of focus, giving intermediate and some of reading vision. And accommodatives and small aperture IOLs are still there, and it's trying to establish their value with time. The popular multifocal option so far until recent times was the traditional with +3 and nearby addition. Typicals are Restore, Technics, Atlisa, etc. And then the low ads with Oculentis, Symphony, and 2.5 Restore. And then came the game changer, trifocals. And now we have even a further improvement on these trifocals as we progress. The trifocals, for your just reminding, it's a 2 focus distance and near 30 to 40 centimeter. And it works out quite well for some people who are using that distance for whatever activity they're doing, but it was realized later on that intermediate vision at 50 or 60 centimeter is more important in the users. For many people who are really doing different activities for their livelihood or for leisure activities, that prolonged distance, intermediate distance, and that term intermediate distance was really never existed several years ago. So that not only the reading vision, that 30 or so distance, but the 60, 70 intermediate was very important. And having understood that, industry came up with the right solutions in trifocals, giving not only the near focus at 40 centimeter, but also intermediate, and with the optical principles involved in the architecture and fabrication of this IOL, it has to end up at 80 centimeter in intermediate distance. And that worked very well for most of the people, but we realized that 80 centimeter could be too far. In reality, the intermediate distance with the average height and the arm length would be little less than 80 centimeters. So PanOptics, with its unique technology of making this different distances, came up with a very smart idea of reducing intermediate to 60 centimeters. So it brought down nearer from 80 to 60 centimeter. And because of that larger central disc involved, a larger area of a flat central distance vision disc, and the technology, the light passing and going to the retina is quite high, probably higher, almost higher than others, but other Atlisa also has a good penetration. And at 3 millimeter, it's very good. So I think if you really want to now go for happy customization, and as we heard in the previous presentation, obviously fundamental is to understand the eye, understand the patient, and have an appropriate solution in terms of intraocular lens. So I'm going to share 1, 2, or 3 cases for you. And this is a very, very typical patients of a cataract population. Any patient who is elderly, not very active, say 70 years nowadays or plus, and with the age, many of them become forgetful. And this lady was one of those, and really had to struggle to get the glasses, find where the glasses been put. So she came to us with the bilateral cataracts. She was active otherwise, not going outdoors or doing any fitness activities, but fairly active in watching TV and reading and everything. So, but she wanted to get rid of glasses. So her ocular profile, and we will come to that in the last talk also, what are the things that we need to look for, was quite okay for receiving multifocals. And we decided, now that we had the PanOptics available, we used the PanOptics, which used the adequate light for this aging retina. And we also explained to her that in a prolonged reading, she would need extra light, not only because of the age, but also with some loss of contrast sensitivity with these trifocals, including PanOptics. So she had the binocular PanOptics put in their eye, and now she's very happy and doesn't need to remember where she has put the glasses on, and she's able to function even if she's indoor, all kinds of activity. So what is it that we learned? That any age, 80 years or 80 years plus nowadays, or any age, is not a bar for multifocal lenses, which includes trifocals, of course. And if the eye is suitable for it, we should consider it, and we should offer it. Maybe they will not go for it for whatever reasons, money or whatever mindset, but we should forthrightly suggest to them that this is one more option, and at this age, you will be able to enjoy this new lifestyle, and you may love it. This is another extreme age, young age, and we get so many young patients, and we all do get many age. This is a very active person. He could be engineer, banker, but this guy was an engineer, and not only blurred vision, but the glare was a real nuisance to him because he drives outside, and he had a motorcycle, and then the glare was really a bother to him. And he was myopic. And remember, young age and myopic. Myopic up to -1, 2, 3 really are eyes which we need to be very attentive, because they've enjoyed that myopic benefit of reading vision. And as Lajja said, it's a birthright, I think. So high myopia, it's okay, but this kind of myopia, which is not very high, not 0.5 or 1, but 1 plus to -3, -4 are an issue. So we need to keep in mind here and all this. And luckily for him, there were no red flags on contraindicating the optical difficulties of multifocal, and she was suitable for multifocal lens. Now, being young, we went one eye, and we wanted to assess how we will do with the other eye. And we told him also, and we were ready to change the strategy in case that doesn't work, because young people, and they are sometimes, we think they are unreasonable in their demands, like the post-refractive patients. So we had to keep in mind his work profile and his personal preference. And many of these have advised them against, and that's not uncommon, particularly with a doctor's reference or doctor's relatives. They send the patient to us that, please ask the Dr. Vasavada not to put multifocal without any knowledge. So this is unfortunately this reality. But the guy said, I want to get rid of the glasses, and I need to see without glasses, if possible, all of the things that I want to do. So we tested in first eye with low ad restore at that time. And we decided to do that because obviously we all need good distance quality vision, and restore low ad had that, and also had additional intermediate vision. And the glare and this photopsia was minimal. And we told him that. So we decided to do that. And he had a good distance vision and reasonable good intermediate vision, but he struggled to read in spite of telling him that he will need reading glasses. So we were just watching how we would behave. But he did suggest that I wish I could read better than this. So we decided to blend this with similar fabrication, in other words, restore, but with a stronger reading ad. And he was very happy binocularly, because now he will be able to see reading as well. But we did warn him preoperatively, and that's very common. And generally, even with the monofocal, we tell them that there is a second eye syndrome, and don't compare the previous eye, particularly on the experience with the operation table. They forget that they had a longer time. They forget that they had a pain and they could not see well immediately, but they want to do that in the second eye. So we do that extensively in every eye, but particularly in this eye. And he still would need selectively for some time. But luckily for him, the blending works very well, and binocular unaided performance was extremely happy, and he achieved what he wanted, as you can see there. So practical outcome was very satisfactory. Doesn't have any more glare because 2.5 really doesn't give that much when it drives at a distance. And only thing is being myopic with minus 1.5. His reading distance was different, and that's what we need to tell every myopic patient, that will happen. Even if you see well, your distance will be different. It won't be the same as you had with the natural myopia. So be aware of you take a lot of chair time. And as I said, they are sometimes we feel it's not very reasonable, but they are not easy to please. And mention about their myopic advantages that they might lose to some extent. This is a very important case, and I want to share with our colleagues, those who are listening here. And the question asked is, what would you do? And there was a survey done on 90 plus or more than 90 ophthalmologists in US, and they asked, what lens would you prefer to have? And those surgeons who are putting more than 50 multifocal IOLs, those who put more than 50 IOLs, they selected 40% of them multifocal. But the rest, those who never put multifocal or less than 50, they went for quality. In other words, they went for monofocal IOLs. So that's the reality. With that background, this is the ophthalmologist of 60 years, still active, bilateral cataracts, and had progressive glasses in his life after the presbyopia. And as you can see here, the toric element as well in right and left. And he's a very busy practitioner, came from other states. Now, remember, we have to have a good crisp microscope vision and a slit lamp evaluation when we check the patients. And we go home, we don't have that, we are not MBAs or CEOs that we have a chauffeur-driven car. Most of us drive ourselves going home. And he was very keen because he had a good experience of his own patient, trifocal IOL. Luckily for him, his ocular profile optically was very suitable. We did discuss in detail at length, which we should discuss with everybody, that you will need some light more in certain conditions, in mesopic low light conditions. And you might see some halos, but if you're positive, it won't bother you and you will not register that very much. So we had binocular optic, panoptic toric lens at the interval of a month. We wait for 3 weeks always between the second eye. We want to see the refractive outcome. Is there any macular edema developing and so on. So we usually wait for 2 to 3 weeks before we operate the other eye. And he was very happy. And he keeps telling us now from where he is that he's able to examine, operate, drive, everything. And it's really not a big thing. So if you are motivated to compromise halos at times or use extra light at times or some reading aids at times, you can improve your lifestyle and consider the Panoptix lens at the time. Now, is the trifocal IOLs for everyone? What I learned from my experience and from my other colleagues at our hospital is that people who are doing a low light jobs, like if you have to drive a long driving in the night condition where there are no street lights, so like highways, and if you do the long one, or if you're doing in a factory or somewhere where it is low light, I would not consider Panoptix or any trifocals because they do need extra light, and it's not possible every time to have more light. I had a patient who was a marketing guy, and we put that multifocal lenses, and he was okay, but every time he visited different offices, the light condition was not ideal. Now, he had to use his mobile light to have that. And he was really upset with that. The doctor, you didn't tell me that I'll need this extra light. So I think those who are working in a very, very low light conditions, I would caution you to consider any multifocal, including panoptic lens. So that's something, but otherwise, the panoptics is very good. As I said, the halo is a trade-off, but it's not very much. And there is some lower contrast sensitivity, and therefore you must remember what I said earlier. And the real strength is that it has really as good a contrast sensitivity performance as monofocal in the average light condition. And the best part really is all the trifocals have that, but particularly in the real life from reading 40 to 60 centimeter to far, there is a seamless, continuous, good quality vision with the panoptics because their intermediate vision now is at 60 centimeters. So most of us have the arm length and the working condition at that point. But other trifocal lenses also work quite well, but we find this one as disadvantage. And then these trifocals and panoptics in particular really give us a great spectacle independence. So finally, pick the right patients, understand it, lifestyle and professional requirement. And luckily, we have a lot of options now. We have these group of lenses, the monovision strategy, the extended depth of focus, and we have one more new lens coming up. And without any financial interest, I know one for sure is from Alcon, a Vivity lens, which also is going to give us another option. I don't know yet very much about it, so I really can't talk. But so we have a lot of options now for our patients, and we can really perform this happy customizing for our patients. But mind you, you must spend a lot of chair time